Welcome to Clinical Capsule, your trusted guide for clear and concise medical learning.
Right now, you are walking around with a biological system so complex that it requires like 5 different cranial nerves and this flawless split-second handoff between voluntary and involuntary muscles just to drink a glass of water.
Yeah, without drowning, basically.
Right, without drowning. I mean, you sit down for a meal, you chew, you swallow, and the food goes down. There's just this expectation of absolute automation.
Oh, totally. It feels seamless. You make the conscious decision to swallow, and your biology simply takes care of the rest.
But then, you look under the hood at the actual mechanics of swallowing, and suddenly that seamless process looks like a really high-stakes, incredibly precarious juggling act.
It really is. One dropped pin, and the whole system crashes.
Exactly. And that is our mission for you today in this deep dive. We are unpacking the shockingly complex biological choreography behind something you do hundreds of times a day without even thinking about it.
It's fascinating stuff.
It is. We're pulling all of this from a clinical chapter titled Dysphagia, Physiology, Pathophysiology, and Clinical Management. And whether you're a medical student prepping for rounds or, just someone who occasionally gets a piece of dry chicken stuck in their chest.
Which happens to the best of us.
Right, exactly. This is going to completely change how you view your next meal.
It fundamentally rewrites your understanding of your own throat.
Yeah.
But to start, we really need to clarify the core concept we're exploring today, which is dysphagia.
Right.
Clinically, dysphagia is defined as difficulty with the transit of food or liquid from the mouth down into the hypopharynx, which is basically the very bottom of your throat, just above the voice box, or down through the esophagus into the stomach.
Because people often hear trouble swallowing and they just lump all throat issues together. But clinically, you have to separate a functional difficulty from a whole cluster of other things that sound similar but operate very differently.
That differentiation is crucial for doctors. I mean, take aphasia, for instance.
Mm-hmm.
While dysphagia is difficulty swallowing, aphasia is the complete, literal inability to swallow.
So a total roadblock.
Exactly. This isn't just a slow-moving process. This is a total esophageal obstruction. It's what happens when a poorly chewed piece of steak gets completely, acutely impacted in your esophagus. Nothing is getting past it.
Yikes. Then there is odynophagia, which is painful swallowing.
Right.
You can have severe pain without the food actually getting stuck at all. That pain usually comes from some kind of mucosal ulceration or inflammation in the throat or esophagus. So the machinery works, but the lining is damaged.
And we absolutely have to distinguish those physical issues from globus pharyngeus.
Oh, right, the lump.
Yeah, this is an incredibly common phenomenon. It's that phantom lump in the throat sensation you might feel when you're anxious or stressed.
Yeah, I've definitely had that.
Right. But the key distinction is that a globus sensation does not actually interfere with the mechanical act of swallowing. In fact, many people find that the sensation is temporarily relieved when they swallow a glass of water.
Which is such a weird trick of the brain, honestly.
It really is.
And finally, there's phagophobia. This is a psychogenic fear of swallowing. I mean, it's a refusal to eat or drink related to severe anticipatory anxiety about getting food stuck, feeling pain, or choking.
Which is completely debilitating.
Oh, I'm sure. But to really understand why swallowing fails and causes all this physical and psychological distress, we really have to understand the miraculous baseline mechanics of how it actually works.
Because recognizing the specific sequence of a normal swallow is really the only way to understand the two distinct zones where things go wrong.
Exactly.
So the journey of a single bite of food maps out into 3 distinct, highly regulated phases. First, you have the voluntary or oral phase. This is preparation. You're masticating the food, breaking it down, and mixing it with saliva to create a cohesive, manageable bowl of food.
Which doctors call a bolus.
Yes, exactly, a bolus.
And you are fully in control here. You can hold a sip of wine in your mouth for 10 seconds or chew a piece of bread for a minute before deciding to swallow.
Right, it's completely voluntary. But then comes the transfer phase. Your tongue physically propels that bolus backward into the pharynx. And once that bolus enters the hypopharynx, that deep lower part of the throat, it triggers the third phase, which is the pharyngeal swallow response.
And this is the critical transition, right?
Oh, absolutely. The process shifts instantly from voluntary control to an involuntary, centrally mediated reflex. It involves this rapid, incredibly complex series of muscular actions meant to shoot food down into the esophagus while aggressively guarding your airway.
Because the airway is right there.
Right there. So to achieve this protection, the larynx, your voice box, is physically yanked upward and pulled forward.
Wait, I'm trying to picture this mechanically. If the larynx is pulling up and forward, what is that actually achieving? I mean, is it just trying to get out of the way of the food?
Well, it's actually this brilliant dual-action maneuver. By pulling up and forward, the larynx physically tucks the opening of your airway up under the base of your tongue, hiding it from the oncoming avalanche of food and liquid.
Okay, wow.
But simultaneously, that exact same upward and forward pulling motion physically yanks open the upper esophageal sphincter, or the UES.
Oh, I see. It's like pulling a lever that simultaneously drops a trapdoor over your lungs while opening the chute to your stomach.
That's a perfect way to describe it.
Okay, so tongue pulsion pushes the food through that open upper sphincter, and then the throat clears out any residue with a sweeping contraction, passing the baton to the esophagus.
Right.
And at the very bottom of the esophagus, your lower esophageal sphincter, the LES, relaxes the exact moment food enters the top of the tube, and it stays relaxed until the food is safely delivered into the stomach.
And that downward transit happens through peristalsis.
Okay, let's unpack this, because peristalsis is a word we hear all the time in biology. But the physiology here is incredibly specific. It's not just one big static squeeze like a python digesting a mouse. The esophagus isn't just a gravity-fed PVC pipe. I mean, it's a segmented smart chute.
That segmented intelligence is literally what keeps us alive. True primary peristalsis is a highly sequenced wave. It begins with active inhibition.
Which means what, exactly?
It means the muscle layers just ahead of the food bolus are chemically instructed to relax and open up.
Okay.
And then that relaxation is followed immediately by a firm contraction of the muscles right behind the bolus, physically milking it downward.
Like squeezing a tube of toothpaste from the bottom up, but the tube is actively opening itself ahead of your fingers.
Precisely. It's coordinated. But the esophagus also has backup systems, like secondary peristalsis.
Okay.
This is a targeted cleanup wave. So if there is local stretching in the tube, say, you have gastroesophageal reflux, and stomach acid splashes up and distends the lower esophagus, the body senses that stretch.
Oh, so it knows it's there even without a swallow.
Exactly. It triggers a secondary peristaltic wave starting right at that specific spot of distension to clear the acid back down without you ever having to initiate a swallow from the mouth.
That's amazing. And then you have tertiary contractions, which aren't helpful at all.
No, not at all.
They are just disordered, spontaneous spasms in the smooth muscle that don't propel anything anywhere. They just cause chest pain.
Yeah, they're just essentially a glitch.
But here's my major pushback on the design of this entire system. I'm looking at this neuromuscular breakdown, and it seems like a massive engineering flaw.
Oh, how so?
Well, the top half of this system, the oral cavity, the pharynx, the upper sphincter, the cervical esophagus, is all striated muscle. That is skeletal muscle, right? The same kind you use to flex your bicep.
Correct.
And it's directly wired to a whole array of cranial nerves firing straight from the brainstem. We're talking the trigeminal, facial, glossopharyngeal, vagus, and hypoglossal nerves, all coordinating in a fraction of a second.
5 distinct cranial nerves firing in perfect symphony just to initiate the reflex.
Well, right. But then, halfway down the throat, the hardware completely changes. The distal esophagus and the lower esophageal sphincter are smooth muscle. And they aren't controlled directly by the brainstem anymore. They are controlled by the myenteric plexus,
which is a local network of nerves embedded directly in the wall of the gut. It basically operates as a sort of independent mini-brain for your digestive tract.
Right. And the chemical messengers completely flip, too. The top half uses normal motor neuron transmitters. But down in the smooth muscle, excitatory neurons use acetylcholine and a peptide called substance P to tell the muscle to squeeze.
While inhibitory neurons use vasoactive intestinal peptide and nitric oxide to tell it to relax.
Exactly. So isn't this dual system, this midair handoff from rapid-fire cranial nerves to local smooth muscle chemical networks, just a coordination nightmare waiting to fail?
If we connect this to the bigger picture, that complex midair handoff is the exact vulnerability of the human swallowing apparatus.
It has to be.
It is. The upper sphincter alone requires the vagus nerve to instantly stop sending excitatory signals to the cricopharyngeus muscle so it can relax, while simultaneously, other nerve are commanding throat muscle to contract and pull that sphincter open.
If that timing is off by milliseconds,
you choke. It's that simple. And because the swallowing apparatus relies on this delicate split system architecture, a failure at the top looks, feels, and is treated completely differently from the failure at the bottom.
So, clinically, the pathophysiology of dysphagia is split into two distinct categories based on what is physically going wrong, right? Structural versus propulsive.
Exactly. Structural dysphagia means the plumbing itself is flawed. The lumen, the inside cavity of the esophageal tube, is physically too narrow, or the food bolus you swallowed is simply too big.
Okay, that makes sense.
To give you some context on size, a normal, healthy adult esophagus has internal dimensions of roughly 2 by 3 centimeters when it expands. It's spacious.
It's plenty of room.
Right. But for solid food to start getting stuck on a regular basis, that lumen usually has to be narrowed to less than 13 millimeters.
Less than 13 millimeters. I mean, that is about half an inch. That's a tiny margin of error if you're trying to swallow a piece of chicken.
It is a massive restriction. On the other side of things, you have propulsive, or motor dysphagia. This means the tube is wide open, but the machinery is broken. The muscles or nerves are failing to squeeze in sequence, or the sphincters at the top or bottom are refusing to relax to let the food pass.
So let's look at what happens when the top of this system fails, what we call oropharyngeal dysphagia. The symptoms here are immediate, chaotic, and pretty dangerous.
Oh, very dangerous.
Because the bolus isn't being controlled or transferred correctly by the tongue and upper throat, patients experience drooling. They might have to try 3 or 4 times just to initiate a swallow.
Yeah, you see a lot of repeated swallowing attempts.
And terrifyingly, the food or liquid can spill prematurely into the hypopharynx before the airway has tucked itself away.
Right, before that trapdoor closes.
Which leads to nasal regurgitation, where liquid literally comes out the nose, or pulmonary aspiration, meaning food and liquid are spilling straight down the trachea into the lungs.
And the causes for this top-level failure are often structural damage from medical treatments, like severe scarring from surgery or radiation therapies for head and neck cancers.
That makes sense.
But very frequently, the causes are neurologic. Conditions that destroy motor control, like cerebrovascular accidents, so strokes, Parkinson's disease, and amyotrophic lateral sclerosis, or ALS, are major culprits here.
Wow.
And regarding stroke specifically, the neurology of swallowing holds a really fascinating quirk.
Oh.
The brain does not split control of the pharynx evenly. There is a distinct asymmetry in the brain's cortical representation of the throat.
Meaning like one hemisphere of your brain takes the lead, acting as the dominant controller for swallowing.
That's the core of it, yeah. And that asymmetry explains why a unilateral stroke, a stroke that only damages one side of the brain, can sometimes cause profound, life-threatening dysphagia.
Oh, because if it hits the wrong side.
Exactly. If the stroke hits that dominant swallowing center, the whole reflex collapses.
Now, here's where it gets really interesting. Let's look at structural failures at the top of the system. There is a highly specific condition called Zenker's diverticulum, which usually affects elderly patients.
Yes, this one is really mechanically fascinating.
Remember that cricopharyngeus muscle we mentioned earlier? The one that acts like a sphincter at the top of the esophagus?
Right.
In this condition, that muscle gets stiff and fibrotic. It acts like a stubborn bouncer at a club who refuses to open the door fully.
So when the throat muscles squeeze downward to push the food through, they essentially hit a closed door.
Yes. And that creates an immense buildup of high pressure in the lower throat. Over time, all that intense pressure pushes outward against a natural weak spot in the muscle wall known as Killian's dehiscence.
It literally blows out a balloon-like pouch.
A pulsion diverticulum, exactly, right above the sphincter. And because there is a pouch sitting right above the entrance to the esophagus, food falls into it and just gets trapped there.
Which is as bad as it sounds.
It is. Patients will actually regurgitate old, rotting, particulate food debris that has been sitting in this pouch for days. It causes severe halitosis or bad breath and poses a huge aspiration risk because that trapped food can just spill over into the airway when they lie down to sleep.
It is a brutal mechanical failure. But if we move down the pipe to the bottom of the system, esophageal dysphagia, the failures present entirely differently.
Okay, let's talk about the bottom.
Structurally, you might see Schatzki's rings, which are actual webs of tissue narrowing the lower tube, or peptic strictures, which is thick scar tissue formed from years of acid reflux burns.
Right.
But you also see complex propulsive disorders that ruin the muscle movement. Scleroderma, for example.
Oh, right.
It's an autoimmune condition that turns tissue rigid. It destroys the smooth muscle peristalsis in the lower esophagus and simultaneously weakens the lower esophageal sphincter.
Which creates a vicious cycle.
It really does. Because the lower door is left wide open, severe stomach acid constantly washes up. And because the peristalsis is destroyed, the esophagus can't trigger a secondary ways to clear that acid back down.
So it just sits there.
The acid just sits there, burning the tissue, which eventually forms a massive structural stricture. You get a propulsive disorder that actively creates a structural blockage.
That's awful. And then there is achalasia, which sounds like the absolute worst-case scenario for the smooth muscle half.
It's quite severe.
Achalasia is defined by two devastating features: the complete absence of peristalsis in the main esophageal body, combined with a lower esophageal sphincter that simply will not relax.
Right.
The tube has lost its ability to squeeze, and the exit door is permanently locked shut. Food just stacks up in the esophagus like cars in a traffic jam.
So
Yeah.
imagine you are a doctor. A patient comes in simply complaining of, trouble swallowing.
Mm-hmm.
How do you pinpoint which of these incredibly specific, varied malfunctions is happening?
Got to be tough.
It is. The symptoms of structural and motor failures overlap heavily, and dysphagia can sometimes be the first red flag for esophageal cancer. The medical detective work has to be flawless. Clinicians use the patient's history as a highly specific treasure map to isolate the exact point of breakdown.
And location is the first major clue.
Right.
If a patient says the feeling of food getting stuck is localized to their chest, behind the sternum, it is almost certainly an esophageal issue.
Yes.
But if they point to the suprasternal notch, that little dip in the neck right above the collarbones, it's much trickier. It could be an oropharyngeal failure right there in the neck, or it could be an esophageal failure further down.
Which throws a lot of people off.
Because it turns out that distal esophageal issues problems way down near the stomach are actually referred proximally up to the neck by the sensory nerves about 30% of the time.
The sensation travels up the nerve pathways, deceiving the brain.
It's exactly like a customer complaining to a plumber about a huge water stain on the living room ceiling. The customer assumes the leak is right above them, but the plumber knows water travels along the joists and the pipe actually burst all the way down the hall in the bathroom. The symptom is far away from the source.
That's a great analogy. And the type of food causing the issue provides the next massive clue.
Okay.
If a patient reports intermittent trouble, and it only happens when they eat solid foods like meat or bread, that strongly points toward a structural dysphagia.
Got it.
Think of a Chatsky ring or a benign stricture. The pipe is physically narrowed so liquids can still slip through, but large solids get jammed.
Right.
But if they have constant dysphagia with both liquids and solids right from the start, that indicates a motor abnormality. The muscles just aren't firing correctly to move anything, regardless of its shape or size.
But there is a huge counterintuitive caveat to that rule when we look back up at the top half of the system.
Yes, what's fascinating here is there is a clinical paradox regarding oropharyngeal dysphagia. Despite having a motor abnormality from nerve damage, these patients consistently report having far greater difficulty managing thin liquids, like water, than they do managing thick solids.
Which totally defies a layperson's intuition. I mean, you'd think a fluid would just slide right down effortlessly compared to chewing and swallowing a solid chunk of dense food.
It defies intuition until you account for the physics of the throat.
Okay.
Remember the rapid, highly coordinated split-second nature of the pharyngeal swallow reflex. Because thin liquids are so fluid, they move incredibly fast.
Ah, I see where this is going.
Right. They require an impossibly fast, perfectly timed reflex from those cranial nerves to elevate the larynx and close off the airway before the water splashes down.
But solids move slower.
Exactly. Solid foods move much slower. Their sheer mass buys the compromised neurological system a few extra fractions of a second to trigger the necessary protective reflexes and shut the airway.
The solid food literally forces the system to slow down. That makes total sense.
It does.
So once the history narrows down the suspect, doctors deploy the diagnostic tools. And the tools completely change depending on whether they suspect a top or bottom failure.
Very different tools.
For that rapid-fire oropharyngeal phase at the top, fluoroscopic swallow studies are the gold standard. This is usually managed by a specialized swallow therapist.
Yes.
It involves the patient drinking various consistencies of barium, which is a chalky, heavy metal liquid that shows up pitch black on an X-ray while standing in front of a fluoroscopy machine, which is basically real-time video X-ray.
And you have to use rapid sequence fluoroscopy because the entire pharyngeal phase of the swallow takes less than a single second.
Wow, 1 second.
Less than 1 second. You need that extremely high frame rate to physically see if the bolus is being retained in a Zenker's pouch, if it's splashing up into the nasal cavity, or, most critically, if it's quietly aspirating into the trachea.
But if the doctor suspects esophageal dysphagia, a problem in the lower smooth muscle half upper endoscopy is the most powerful tool.
Endoscopy is crucial down there.
Right. Endoscopy involves sedating the patient and passing a flexible camera down the throat. It is the gold standard for the lower half because it allows doctors to directly visualize the mucosal lining for inflammation or tumors far better than a barium shadow can.
And crucially, it allows them to physically take tissue biopsies.
Which is vital.
Yes. Taking biopsies is vital for identifying a condition called eosinophilic esophagitis, or EOA.
Oh.
It has rapidly emerged as a leading cause of dysphagia in both adults and children.
And what exactly are eosinophils?
Eosinophils are a type of white blood cell heavily involved in allergic reactions. They have absolutely no business being in a healthy esophagus.
Ah, I see.
But in EOE, an allergic trigger causes these cells to invade the esophageal lining, leading to severe chronic inflammation, stiffening of the tube, and eventually strictures. It is strongly associated with a personal history of severe allergies, asthma, or eczema, especially in younger Caucasian males. Clinical guidelines now mandate obtaining esophageal mucosal biopsies routinely when evaluating any unexplained dysphagia, even if the lining of the esophagus looks perfectly healthy and pink on the camera.
Because the inflammation is microscopic, but the stiffening effect on the muscle is profound.
Exactly.
Okay, so the complex detective work is done. The specific mechanical roadblock or motor failure had been isolated. Now the clinical focus shifts entirely to the physical interventions required to restore a patient's ability to eat. We essentially have to stretch pipes and retrain nerves.
Right. And treating the top half, oropharyngeal dysphagia, is uniquely challenging because the damage is so often hardwired into the central nervous system. You can't just cut away a stroke.
Right, unfortunately.
Surgical intervention, like snipping the cricopharyngeus muscle to force the sphincter open, is generally not helpful for most patients, with the rare exception of fixing a structural Zenker's diverticulum pouch.
So what do they do?
Well, the primary treatment relies heavily on intense physical therapy. Swallowing therapists teach patients highly specific head postures, like a deep chin tuck, which manually alters the geometry of the throat to physically protect the airway during a swallow. They also systematically alter the viscosity of the patient's diet, thickening liquids so they move slower.
But if someone has a progressive neurological disease like ALS and their choking risk is incredibly high, why not just bypass the mouth entirely? I mean, put in a feeding tube directly to the stomach and eliminate the danger.
It seems perfectly logical, but it ignores a grim clinical reality. While feeding via a nasogastric tube or a direct gastrostomy tube provides essential, life-sustaining calories, these tubes do absolutely nothing to protect against aspiration.
Wait, really? How?
The patient is no longer eating by mouth, but they are still producing liters of saliva every day.
Oh, God.
If their swallow reflex is broken, they will still aspirate their own salivary secretions. Furthermore, they are still at high risk of aspirating reflux gastric contents that travel back up the esophagus and spill into the unprotected airway.
Wow. So you bypass the mechanical feeding failure, but the airway remains fundamentally vulnerable to the patient's own internal fluids.
Exactly. It's a very difficult reality.
So what does this all mean for the bottom half? What does treatment look like for esophageal dysphagia?
It turns out to be surprisingly aggressive and mechanical.
Yeah. For the vast majority of structural blockages, doctors literally stretch the pipe. They use tools called bougie dilators, which are essentially a series of progressively thicker, weighted, flexible tubes or inflatable balloon dilators, passing them down the throat to forcefully stretch and tear the scar tissue of a stricture or a Schottky ring to widen that 13-millimeter gap.
It is a direct physical remodeling of the tissue, and it is often highly effective.
Amazing.
For achalasia, where the lower sphincter is clamped shut, surgeons might literally slice the sphincter muscle open to break the tension.
Wow.
And for eosinophilic esophagitis, the treatment shifts away from plumbing and into immunology. The strategy revolves around meticulously eliminating dietary allergens to stop the immune response or administering topical glucocorticoids.
But the delivery method for those steroids is fascinating. You don't inhale them like asthma medication.
No.
You swallow a thick, concentrated slurry of topical steroids. You are literally coating the inside of the esophagus as the fluid travels down, applying the anti-inflammatory medication directly to the surface of the allergic tissue.
It is a highly targeted, localized approach to shut down a specific cellular failure point.
This whole journey really highlights how deeply incredible and honestly incredibly fragile this daily system is.
It really does.
We are talking about a neuromuscular relay race that begins with your conscious, voluntary control of the trigeminal and facial nerves in your mouth. It then passes the baton midair to a rapid-fire, involuntary vagus nerve reflex in your throat that yanks your voice box out of the way.
A reflex you don't even think about.
Right. And finally, it hands off to an entirely separate, local, smooth muscle neural network in your esophagus to actively milk the food home to the stomach. And when any fraction of that delicate transfer of power fails, the medical detective work required to unravel the symptoms and fix the plumbing is nothing short of remarkable.
It is one of the most sophisticated, high-stakes physiological sequences the human body performs.
Huh.
And, there is a vital underlying concept in the physiology that truly reframes everything we've explored today.
Oh, what's that?
Well, the clinical reality is that symptom reporting of dysphagia is entirely dependent upon intact sensory innervation and central nervous system perception.
Which means if the sensory nerves in your throat are damaged and you can't feel the food moving, you don't actually know the system is failing.
Exactly that. If your central nervous system's perception is impaired, perhaps due to a minor stroke, advanced age, or a neuropathy, you could be experiencing what clinicians call silent dysphagia.
That's terrifying.
Your throat's transit system could be wildly uncoordinated. Your body could be failing to transport food, or much worse, silently, slowly aspirating liquids and saliva right past your vocal cords into your lungs.
Oh, wow.
And your brain simply fails to trigger a cough or sound the alarm because the sensory wires are cut.
That is a profoundly unnerving thought. We assume choking is always a violent, obvious event.
Right.
But this is a reminder of how deeply we rely on our body's internal, invisible warning systems, on those microscopic sensory pathways, to tell us when a completely automated process has quietly broken down.
It's a huge shift in perspective.
It is a testament to the immense complexity hiding just beneath the surface of everyday life. And it is definitely something for you to chew on the next time you sit down for a meal, take a sip of water, and expect it to just seamlessly disappear.